Hi everybody, this is Prof Carol-ann Benn. Here we are, October's Breast Awareness Month, and it's quite nice to theme awareness with things that are important to us, such as art. So I want to talk about breast cancer awareness as an art. So the first thing is, a bit like art appreciation, for me is amazing. I can't paint for anything, but I really appreciate good art. Awareness, whether it's your body awareness or your breast, is not just about October, it's about January to December. The most important thing is to know your norm. So you want to understand your body, you want to check your body, and if things don't feel right, you want to know how you can access healthcare. So healthcare access is a very important thing for me. It needs to be equitable. We need to make sure that people who have access to insurance or not insurance have access to care. So the first thing you do is you're going to check your breasts. How are you going to check your breasts? You're going to examine them with the flat of the hand. But before you even do that, take your top and your brow off and give your breasts a wiggle and a jiggle, because by doing that and lifting your arms above your head, you get to see if your nipple is pulling in or if there's anything pulling in or any changes on your skin. Look at the brown area around your nipple. That should just, it usually has little white dots on it. Those are Montgomery's follicles and you don't need to worry. But if you have changes on your nipple, such as scaling on your nipple, then you need to see someone to make sure you don't have a very unusual rare type of cancer called the Paget's. Changes on the nipple, such as the nipple doing a smiley face or pulling in, can be just as simple as inflammation in the ducts. But when you lift your breast, if the nipple pulls in, that's called nipple retraction, and we really want to know about it. And then you need to see someone in healthcare so that they can examine your breast and organize the right investigations. So when you feel your breast softly with the flat of your hand, and when you check for glands under your arm, relax your arm at the side. When you go for your mammogram and ultrasound, they lift your arm up, but you're going to check with your arms down because that's the easiest way to feel the lymph nodes. So you want to look for anything that changes from month to month and make sure you see someone in healthcare. So let's look at the breast. Okay, I really like the picture on the left. We'd all like breasts to look like that, but the picture on the right is what your breast really looks like. So you have 35 to 50 tiny little ducts going into the nipple and ducts going back to lobules, which are really the milk producing unit. So fun fact, men have breasts as well as women, okay? They just don't have lobules and they can't produce milk, but they can get breast problems as well. Men commonly get MOOBs, male breasts, and even men can get breast cancer too. Remember, breast cancer has no bounds, neither over age, race, or sex. So we want to be aware, both men and women, and you want to check your breasts. So what things can you find when you check your breasts? You can find little lumps, and remember, we don't have eyes on our fingers, so if you find lumps in your breasts, what you need to do, no matter what your age, is go for an ultrasound. An ultrasound is like Binocs. It checks your breasts to have a look to see if the lumps are solid or cystic, because it's quite common to have your breast grow little bubbles and little cysts. So what else can you find? You might find a hard lump and you might be concerned. And then again, you want to go and seek help to make sure it's not a breast cancer. The nipple is a glorified plug. Don't squeeze your nipple. But if you see a leak, particularly clear blood or yellow stain fluid, go and see somebody, because it can be a tiny little growth in the duct called a papilloma that's really hard to see. If you squeeze your nipples, you will produce a substance. And obviously, women who are breastfeeding produce milk. And the commonest thing that causes milk production is the baby sucking on the nipple. So therefore, don't squeeze your nipples. All women have breast pain at some stage in their life. So the bigger your breasts are, the heavier they are. Breasts sit on a fine netting that goes from your neck all the way down. And it's not uncommon to get pain on the sides. Pain on the sides is often inflammation in the underlying ribbon structures and is called costochondritis. The other type of pain you can get is burning, shooting pain through your breast, which is inflammation in the ducts. And then you can get hormonal pain, pain during different phases of your cycle. Again, see a unit that has an interest in breast health. They can send you reading around managing breast pain. Most of the management is with natural medication, okay, and mechanical, making sure you're wearing the right size and shape bra. So what happens if you think you've got a breast cancer, or someone tells you you've got a breast cancer? So I just want to remind everyone that the diagnosis of breast cancer is not in the hands of a surgeon. If you find something concerning, you go for an ultrasound if you're under 35 and a mammogram and ultrasound if you're over 35. If they see something on the mammogram and ultrasound, they will recommend a biopsy. The biopsy is not done by the surgeon, but done by a specialist radiologist under proper guidance so that they can see exactly where they're putting the needle. There is no such thing as an emergency biopsy. Understand the costs before you go and make sure your mammogram and ultrasound is reviewed properly, because sometimes you can avoid biopsies and do short-term follow-ups. We do a core needle biopsy to diagnose a breast cancer, and when we find a breast cancer, you need to understand it's not running around your body like little shopper horrors. Breast cancers are slow growing, so you want to take time and you want to make sure that all your information is reviewed in a multidisciplinary environment where there are lots of specialists from different disciplines discussing you. You want to make sure your feedback is also via navigators. So you don't have a surgeon saying to you, I'm discussing you and we need to cut, or an oncologist saying, I'm discussing you and you need chemo. By discussing everything and coming up with a plan, we can personalize and tailor a plan just for you. Because today we know that there are many differences in terms of how we treat breast cancer. We are de-escalating treatment, which means less is more, which means most women don't need to have things such as a mastectomy. In fact, we encourage the less is more approach, where more ladies have breast-saving surgery, and in fact, in some instances, you might not even need an operation. So you want everything discussed. We divide breast cancer into 4 different types. So how do we look at breast cancer? It's a bit like saying you treat TB different to malaria, different to a bacteria, and different to a fungus. So by dividing breast cancer into 4 biological types, we treat those cancers according to their types. The umbrella under which all cancer treats should be oncology. So you can have an asleep cancer or an awake cancer. Cancer that's confined in the ducts is called a duct carcinoma in situ and is an asleep cancer, and we treat it differently. And an awake cancer, what we want to understand is how it behaves in case you need to have some form of oncology. I didn't say chemo. Certain medication to shrink that cancer down. It can be a target. It can be cytotoxics, which is what we understand as chemo, and there are many different types, again, of chemotherapies. Under the umbrella sits surgery, and surgery often goes hand in hand with radiation. And radiation, like surgical treatment, is also de-escalating today. So you often need less, and you can have smaller amounts of radiation. But you want the whole concept of your treatment personalized for you. We encourage prehab. Speak to people before you go into your treatment to help you through your treatment. And after treatment, we encourage surveillance and survivorship. So after you've had your acute treatment, who's looking after you? Who's making sure you and your family are safe and that you feel held and you don't feel traumatized by what you've been through? What I want to stop and mention now is 65% of people who get breast cancer have no risk factors whatsoever. So that for me is always interesting, because people say, it wasn't in my family, I can't believe I got it. So let's say hormones. I often asked about contraceptive pills and fertility treatment and hormone replacement therapy. They don't cause cancer. Cancer is an abnormality that happens in a cell line. So cells divide, you get little abnormalities in the cells, and the environment around the cells often tries and kills that cell. If it's not able to do that, it grows this little weed cancer plant. Okay, so 65% of people, no risk factors. 25% have family history on their father and their mother's side. That's why you need to know your family history, and particularly if you've got cancers that occur in the family at a younger age. Certain types of cancers we are more concerned might have genetic abnormalities associated with them, and these are important for how you screen and check down the line. Sometimes a little bit about what treatment is offered, not about what surgery is offered. Then 10 to 12% of people can have a single gene mutations around their breast cancers. So it's not as common as you think. Obviously, we encourage people to understand their genetic makeup because there's power in knowledge. So here we have like a breast ribbon ECG, and I always feel it's like the palpation in your heart when you think there's something going on. What do I do, and where do I turn for help? And I encourage this concept of ghost busting. You need a team around you that are going to help you take time with your decisions, write them down, record what the doctor said, and then you need to choose your medical ghost busting team quite carefully. You need to make sure that there's robust review, that there's an opportunity to discuss issues. I'm very anti this 1, 2, 3 rush into treatment. Rather, take time. I'm not saying months and months and months and months, but really one step at a time. What are my options? What are my feedback? What is specific about me that you can incorporate into your breast cancer treatment? Okay, so surgery. Okay, you see the ribbon on the breast there, that's a beautiful pic. The other one is nice and abstract. I really like the blues. There's a new trend. I had one of my patients, they were unhappy around scars of surgery that they'd had elsewhere, and they'd put this whole pile of tattoos across their chest wall and their breast. So breasts are so personal, and I think it's very, very hard for people to go through any form of surgery on their breast. I don't think people turn around and go, oh, you know, well, I'm in it because so you can treat my cancer and you can make it look nice. I think what we've got to understand that it's hard to go through cancer treatment, and most of us will try and avoid operations and treatments as much as possible. So we need, as a medical fraternity, to take cognizance of the fact that when we operate on breasts and we leave scars, that it affects people in the short term and in the long term. So always, and you've heard me say before, less is more. Do less rather than more. So don't rush in and go, oh, I'm taking both my breasts and I'm doing this and I'll put prostheses in, because if something goes wrong or you're not happy with it, you can't really reverse it. But when you do smaller procedures and just take out the cancers, and we smaller with the amount of glands we take today, we take very few, it means that you can manage the sequelae of the surgery so much better. Survivorship. Okay. So I think we all go through traumas in our lives, whether it's cancer or other traumas, and life is really about one day at a time and making sure you're getting something forward, but also dealing with the mental anxiety around what you've been through yesterday or been through in the past. And if you've been through a cancer diagnosis, then you get what I call, and I mean I have it too, it's canceritis, where every time you're not working or you do something, you think, what's that? Is something happening in my elbow or my shoulder, or why have I got a pain here, or why I've got a headache? So we need to realize that any trauma changes how you look at yourself and the people around you going forward. And it's working that into how you are going to manage in your day-to-day life, work and home. Exercise, spectacular. There's a lot of data that shows that if you exercise, you decrease your chance of getting cancer, and also it decreases your chance of cancer coming back. So I think we need to go forward victorious. No matter how scary the subject of cancer is, we need to check our breasts, we need to be grateful every day, we need to go for our screening. Screening is not just about breasts, it's about breast, gynae, in men, prostate, stomach, colon, and in us blondes and fairer face, skin as well. So do your routine screening. Here we go. Well, how's that for a beautiful flower? My favorite flower is the sunflower, and I mean that this is spectacular. And sometimes I like sunflowers because they're functional flowers. The fact that you know, whether they are in bloom or whether it's just the seeds afterwards, there's always a part of them that you can use. And when you look at this beautifully made together flower, you realize that's really for all of us every day. We're going to make bits of our day. We're going to screen. We're going to check our breasts. We're going to be positive. We're going to help someone else. Give forward and help somebody else, so that help them when they need to go for their screening and their tests. So I'm going to thank everybody and wish everyone well. Enjoy art. Enjoy your bodies. Enjoy. Thank you.